a freshman in the Integrated Life Science Honors Program, majoring in cell biology and genetics with a minor in disability studies. Hi guys, I'm Alex. I'm his twin. I'm also majoring in cell biology, molecular genetics, minor in disability studies, and I'm also a member of the Integrated Life Science Honors Program. And today, we're going to be talking about gun discrimination, barriers to oral health for people with disabilities. So when we hear the term medical discrimination, what comes to mind? Oftentimes we think about race, gender, socioeconomic status, but rarely do we think about the dental trend. Dental discrimination should be recognized as a form of medical discrimination because one's oral health is directly linked to the overall health. In fact, the mouth is a gateway to the rest of the body. Dental diseases such as dental decay and periodontal diseases are not isolated conditions. In fact, it's been proven that bacteria from the bloodstream can actually travel through the bloodstream and cause increased risk of diseases. And this is the reason why people with disabilities who have poor oral care are often subjected to increased risks of conditions such as pneumonia, malnutrition, diabetes, systemic infections, and even cardiovascular diseases. However, despite these increased risks, there are still many barriers that prevent individuals with disabilities from having access to proper oral care. In fact, according to an analysis conducted by the National Health and Nutrition Examination Survey from 2015 to 2018, it was found that adults in the United States with disabilities were around 2 times more likely to have unmet dental care needs compared to individuals without disabilities in the United States. And this signifies a significant, and this is an issue because medical discrimination occurs when systems create unequal access to care for a specific population. And that's exactly what we're seeing here for people with disabilities facing unmet dental care needs. So, working at a dental office, we've witnessed firsthand how the needs of people with disabilities are often neglected. Many patients with disabilities or their caregivers often express frustrations about how their previous providers were too uncomfortable treating them. And what really surprised us was how the discomfort of the provider was internalized by the patient. And this resulted in a reluctance of getting treatment, or a fear of going to the dentist that was still evident when the patient sought out treatment at our practice. And when we examined the literature, we realized that this wasn't an isolated issue, but rather common problems that result from systematic shortcomings in dental education and access. In fact, a 2025 CareQuest research report found that of the 9,307 participants surveyed, 43.9% of people with disabilities said that their last dental checkup was over a year ago. And this is especially concerning when you consider how the American Dental Association recommends that the average time between dental checkups should be around 6 months. These checkups are necessary in removing hardened plaque that normal brushing can't get rid of, and for the early diagnosis and treatment of issues such as dental decay and gum disease. Now, a major reason for why people with disabilities are seeking out proper oral care is actually because of the distrust they have of their dentist, who is sometimes too uncomfortable or lacks the proper training to adequately treat their needs. And this is a very big issue because it can lead to 2 main kind of consequences. Firstly, there's an economical detriment because since the issue has been allowed to spread for long periods of time, the cost of treatment will be higher. But more importantly, the treatment also becomes much more invasive. And this is because this is especially important for people with disabilities because they often have issues such as uncontrollable body movements, hypersensitivity, and greater degrees of anxiety that can overcomplicate and even jeopardize more invasive treatments. And something that I would like to illustrate is that the same 2025 CareQuest research report that I talked about earlier also said that nearly 1/3 of people with disabilities said their provider doesn't provide them with any sort of special help or accommodations. And what's worse is that many people with disabilities are simply told by the provider to simply go somewhere else. And so the discomfort that's caused by the lack of training for the dentist or the overall unwillingness to treat people with disabilities cycles back to the patient. And this results in the patient not wanting to seek out proper oral care and have these detriments. And just to illustrate this, many people with disabilities at our practice who neglected preventive care from their previous providers were also individuals that required the most invasive forms of treatments. For example, there would be dental decay that is completely compromised the tooth. And when this happens, the dentist has to perform an extraction and subsequently follow up with a dental implant. Firstly, this is very expensive. It can cost around $3,000, but more importantly, it's also much more invasive. And this is because, as you can see here, the dentist literally has to place a titanium bolt into the jawbone of the patient. This is a procedure that requires many more visits and longer treatment times. So as a result, the patient with a disability is physically strained on the chair for longer and more frequently, and there's a greater likelihood that something could go wrong. And the worst part about all of this is that the entire issue could have been prevented had the patient gone to the previous provider and had the issue diagnosed early on, in which case all that would have been needed would have been dental filling, where the dentist removes the surface level cavitation and replaces it with a steep resin. This treatment is much less expensive. It costs around $200 to $600, but more importantly, it's also minimally invasive. But because people with disabilities are receiving proper oral care, they have to rely on more invasive, more arduous, and more expensive forms of intervention rather than prevention. And what's worse is that it's not just oral health that's affected, but overall body health as well. When we go to the dentist, we prevent the severe accumulation of plaque from building up in the mouth and potentially entering and infecting the bloodstream. And this is a very prevalent issue for people with disabilities. In fact, the leading cause of death for someone with an intellectual disability is a respiratory infection such as pneumonia. And just to quantify this, according to a 2020 study conducted by LANS, it was found that adults with an intellectual disability were 20.8 times more likely to die from a respiratory infection such as aspiration pneumonia. And now, the good news is that part of the solution is actually going to these dental checkups. Another population-based study conducted in 2020 by Sun et al. Found that the group of people that were at lowest risk for developing pneumonia were those that frequently brushed their teeth and frequently went to the dentist for treatment. Whereas the group of people that were highest risk for developing pneumonia were those that didn't go to the dentist. So there is a link between going to the dentist and reducing the risk of prevalent issues such as pneumonia. However, if the dentist is unwilling to treat someone with a disability, then the patient really only has two options. They can either, one, become more susceptible to the adverse health effects that arise from oral health negligence, or two, seek out care from a different provider, which is oftentimes in a location that's even less accessible. For example, there was a patient there was a mother at our practice that I work at who used to have to take her son every 6 months all the way to the University of Maryland School of Dentistry, even though she lives in Montgomery County. And this is because no one in her area wanted to treat someone with an intellectual disability. And she was fortunate because she had the means, the time, and the capacity to make the hour-and-a-half drive every 6 months. But for many people, this is not the case. So the bottom line is that there has to be more dentists that are willing to treat people with disabilities. However, an untrained dentist is equally as detrimental. And for example, some of the things that a dentist do is use sedation when they're dealing with someone with a high degree of disability. And this is so that the uncontrollable body movements don't potentially jeopardize the treatment. However, sometimes the sedation is not necessary and only used for the comfort of the provider. And when this happens, it unnecessarily exposes the patient to the cardiovascular and respiratory inherent risks that are associated with sedation. But more importantly, the treatment also becomes much more invasive. For example, at the practice I work at, there's someone with an intellectual disability whose previous provider automatically referred him to a sedation clinic because of the status of his disability. And the mother of the patient found out that she would have to pay $500 to $1,000 per hour that the sedation was going to be administered, along with the fees for the fillings that would have to be paid out of pocket. And so the total cost of this treatment was going to amount to around $8,000. Now, obviously, the mother didn't want to have to pay this much money because it's very expensive. But more importantly, she firmly believed that her son didn't need sedation. So she went to our practice and asked the dentist to do all the fillings without using sedation. And this was very possible. It took around 4 to 5 treatment days, but more importantly, the total cost of the operation was around $1,500, which is less than 1/3 of what she would have had to pay if the dentist relied on sedation. So the bottom line is that dentists have to also be not just willing, but also trained on how to adequately assess the situation and respond accordingly. So last December, based on our experiences working at a dental office, we were motivated to, and we actually received a grant from our Honors College program, the Integrated Life Sciences College, to pursue our service project of increasing access to oral care for people with disabilities. And so our project consists of assembling oral hygiene kits, interviewing dentists, and collecting data from questionnaires which we distributed to both dentists and individuals with disabilities and their caregivers. Currently, we're in the process of assembling and distributing oral hygiene kits, which are tailored towards individuals with disabilities and their caregivers. And we're partnering with dentists to reduce the cost of these kits and by including some of the donated materials in these kits. Additionally, we're also including infographics which will educate both the patient with disabilities and their caregiver on some of how to properly maintain oral care, as well as the often overlooked link between one's oral health and the systemic body health, including the link between poor oral health and an increased risk of respiratory illnesses. We're also setting a time for a distribution date with the Community School of Maryland, which is a school that educates individuals with disabilities. And we're working to ensure that every student at the school will receive an oral hygiene kit. To better understand the barriers that individuals with disabilities face when trying to receive oral care, we interviewed a dentist who had a master's in public health. And we also set up multiple other interviews to kind of understand from the provider's perspective what are some of the difficulties that come when trying to treat patients with disabilities. And what we took away from these conversations were that many of these challenges were not isolated issues, but rather part of a broader recurring theme. In fact, these challenges closely aligned with the literature that we're reviewing, as well as our own observations working at a dental office. Many of the dentists identified these 4 primary barriers, which include the lack of provider and staff training, limited oral health literacy, affordability challenges, and caregiver dependence as the main barriers that prevent them from properly treating patients with disabilities. But one of the most striking things that we took away from these conversations were that many of the dentists were not directly unwilling to treat patients with disabilities, rather they expressed a fear of the unknown. And they attributed this fear of the unknown to a lack of adequate training and exposure. Many of the dentists reported that they felt unprepared when it came to treating patients with disabilities, and it means that it's not necessarily a problem of intention, but rather a problem of preparation. And this can be seen as a form of unconscious or unintentional discrimination. Oftentimes, the majority of dentists aren't necessarily directly avoiding or excluding treating patients with disabilities. Rather, the lack of adequate training and exposure often results in discomfort and feelings of avoidance, which ultimately lead to unequal access to care. And this is actually shown here. So this is, like I said earlier, a problem of training, and it signifies a very large educational gap. In fact, most of the dentists reported that during dental school, none or less than 1% of the patients that they treated actually had a disability. And this percentage remained similarly low during private practice. Additionally, the majority of dentists also strongly disagreed that dental school adequately prepared them for treating patients with disabilities, highlighting the significant educational gap. And this is important because it highlights a critical issue. It's that many patients with disabilities often struggle to find providers who can adequately meet their needs and give them the dental treatment that they require. And this doesn't just result in inconvenience, it can result in delayed care, increased health consequences, or no care at all. So like I said before, the problem isn't necessarily a direct lack of willingness, but rather systemic gaps in education, financial structures, and institutional support. Current potential solutions should work on targeting both incoming providers as well as current practitioners and create meaningful structural incentives. Because there are many dimensions to this issue, and while we cannot address all of them, working on increasing provider experience and exposure are crucial steps forward that we should be taking. So the first potential solution would be a loan forgiveness or loan reduction program in which recently graduated dental students would participate in structured clinical training programs on how to properly treat and care for patients with disabilities. Afterwards, they would dedicate some of their time to working at publicly funded clinics in order to serve patients with disabilities. And this would do 2 things simultaneously. One, it would increase the workforce which is capable of treating patients with disabilities, and would also reduce the financial stress that many recently graduated dentists face when they just come out of dental school. The second potential solution would be a formal certificate program in special care dentistry, which would emphasize clinical competency, behavioral management, and disability awareness, and it would serve as a recognizable credential for individuals with disabilities and their caregivers as to which providers can best meet their dental needs and provide them with the best adequate care. The third potential solution is actually the one that we're most strongly advocating for. Just to give you some context, every 2 years, dentists are required to complete mandatory continuing education credits to renew the license. So the third solution would be to include these mandatory disability trainings into these continuing education requirements. And pretty much making training to address a certain issue under continuing education credits has actually already been done before. And an example of this is the program PAMPAS, which means Prevent Abuse and Neglect Through Disability Awareness. What ended up happening was that many times, many teenagers and children often go to the dentist for routine checkups every 6 months. And this makes dentists one of the first people who can recognize signs of abuse and neglect. So when the issue is necessary, then the credit for that issue can also become mandatory. And so incorporating disability training into these continuing education requirements would increase dental preparedness on a much broader scale. And the effectiveness of these approaches has actually already been seen. According to a study conducted by Chavez in 2011, it was found that dentists who treated medically compromised patients during dental school were actually more likely to treat medically compromised patients during private practice. So this means that clinical exposure directly influences provider behavior. As clinical exposure increases, discomfort decreases, and providers become more confident, competent, and more empathetic, and can better treat patients with disabilities. Ultimately, these forms will not only increase equitable access, especially for patients with disabilities, but they will also work to ensure that treating patients with disabilities becomes a normalized part of healthcare rather than an exception. Now, some might argue that the important change has already happened and that it's only a matter of time. And this is because the National Council for Disability said that in 2020, all dental schools in the United States have to include some form of mandatory training on how to treat people with disabilities. And while this is a good step in the right direction, it does nothing for the many existing dentists who have already graduated prior to the curriculum change. And when we consider how the career span of a dentist is often decades long, we can't wait for the change to happen. We have to begin implementing it now. And just to conclude, when we take a step back and look at all the issues that we've discussed, we realize that we're not talking about two isolated problems, rather two very prevalent realities in healthcare. Firstly, dental disease remains the most common non-communicable disease in the world. And secondly, 1 out of 4 individuals in the United States has some form of disability. So the intersection of these two realities reveals systematic shortcomings in our healthcare system. Because if the most susceptible population is receiving the least amount of care, that's not a coincidence, that's an equity. Through our grant project, we have learned that training, incentives, and accountability measures must all work together to ensure that treating patients with disabilities is not viewed as specialized or optional, but rather as a fundamental responsibility within healthcare. And thank you.